Dear ladies and gentlemen, dear colleagues, hello from Germany. My name is Christoph Rollig. I'm a consultant hematologist here at the University Hospital in Dresden, Germany, and I'm very honored to give you my view on the current treatment of newly diagnosed patients with acute myeloid leukemia who are eligible for intensive treatment. These are my disclosures. First, I'd like to start with a couple of words regarding the AML classification. As you may know, we have two parallel classifications since last year, an update of the WHO 2022 and a new international consensus classification also from 2022. Now, whereas WHO classification is mainly based on pathophysiological considerations, the International Consensus Conference paper puts more emphasis on the clinical management of patients. You may agree with me that the two classifications are a rather painful situation, but I can comfort you at least by saying that I do think that in the near future we will have one joint classification again. And I can maybe also for the time being comfort you by saying that these two classifications have a lot in common. They agree that recurrent genetic abnormalities, if they are present, should define the AML and not blast counts or something like that. They are almost identical in their definition of genetic abnormalities. Myelodysplasia-related genetic and cytogenetic abnormalities are also mentioned in both classifications. Treatment-related AML is mentioned as a so-called diagnostic qualifier in both classifications. The AML entity with multilineage dysplasia has been removed by both classifications as opposed to WHO 2022, WHO 2016. And there is an entity called myeloid neoplasms with germline predisposition existent in both these classifications. Differences between these two classifications affect the minimum blast count in recurring genetic abnormalities. Then the blast count between 10 and 19%, which is called MDS increased blast 2 by WHO and MDS/AML by ICC. In patients with recurring genetic abnormalities without recurring genetic abnormalities and more than 20% blasts, this is called AML defined by differentiation by WHO, where it is called not otherwise specified by ICC. We have a separate entity of TP53 mutation AML in ICC, but not on WHO. And we have almost identical, but only very slightly different genetic abnormalities defining myelodysplasia relatedness in these two classifications. And the term AML, myelodysplasia related changes from WHO 2016 is now called AML-MR by WHO 2022. And is no separate entity in ICC, but is kind of subdivided into entities called with myelodysplasia-related gene mutations, cytogenetic abnormalities, or in the diagnostic qualifier called progressing from MDS-MPN. Now, this is my conclusion on the two different 2022 classifications by WHO and ICC. They both put a stronger focus on the genetic predisposition than on morphology or the blast count. And the boundaries between MDS and AML are increasingly blurred. The classifications rather have biologic prognostic implications than therapeutic implications. And because of that, treatment decisions should not be based on these two classifications, but on blast count and blast kinetics, on the blood counts, the presence of cytopenia, the clinical performance of patients, therapeutic subgroups, as I will mention later on, targetable lesions, as I will also refer to later on, and the ELL risk stratification in order to judge the responsiveness to chemotherapy and the mode of post-remission treatment. At initial diagnosis, we first have to decide whether a patient is fit for intensive curative treatment or not. And you know that we have different treatment options for these two groups of patients. And within the next couple of minutes, in the interest of time, I will focus on fit patients who are eligible for intensive curative treatment. The main determinant for response and remission in AML is the individual genetic abnormality of patients. And for this, we also have a new classification by the European Leukemia Net. It was updated also in the last year, 2022. And you can see here that the main differences is how FLT3-ITD is treated. Every patient with FLT3-ITD is now intermediate risk. We have a specification for CBP alpha mutations in the way that only B-zip in-frame mutated CBP alpha is now good risk. And we have an addition in adverse genetic lesions by two very rare translocations, but also by the addition of the so-called secondary type molecular changes, secondary type mutations. Secondary and treatment-related AML mainly have high-risk genetics, and that's why their prognosis is worse than the prognosis of de novo AML. So how do we treat newly diagnosed fit AML patients? The backbone of intensive treatment still is the induction with a 7+3 intensive chemotherapy regimen, followed by either post-remission treatment with chemoconsolidation, cytarabine-based, or allogeneic stem cell transplantation. Now, this is the subgroup-specific addition or specification of induction treatment. Patients with CBF or NPM1 mutated AML should have gemtuzumab orzogomycin in addition to 7+3. FLT3 mutated patients should have midostaurin in addition to intensive chemotherapy. Patients with AML with myelodysplasia relatedness or treatment-related AML should receive CPX351, liposomal formulation of chemotherapy, whereas patients with intermediate risk should receive 7+3, and then depending on the patient fitness and also CD33 expression plus minus gemtuzumab orzogomycin, whereas for the rest of patients with adverse cytogenetics or adverse features that do not fit into either of these categories here, we still only have 7+3 induction chemotherapy. Patients with secondary or treatment-related AML have a high unmet medical need, and for a large proportion of these patients, we now have a treatment option with liposomal with a liposomal formulation of cytarabine and daunorubicin that is called CPX351. It contains the two agents, cytarabine and daunorubicin, in a fixed molar ratio. Due to the lipophilic properties of this drug, it accumulates in the bone marrow, which causes longer cytopenias in patients, but also less side effects in the rest of the body. So patients quite frequently don't have hair loss, for instance, as a result of this chemotherapy. The CPX351 preparation contains a lot of copper, and that's why its color is purple, as you can see in this picture. The drug CPX351 was approved based on a randomized trial in elderly fit patients with secondary or treatment-related AML who were randomized to receive either CPX351 or 7+3 induction chemotherapy, followed by consolidation treatment. Patients with CPX, here in the purple line, had a significantly longer overall survival than patients who received induction chemotherapy with 7+3. And this overall survival benefit was most impressive when patients were transplanted in first CR. So if patients received allogeneic stem cell transplantation first CR and they were pre-treated with 7+3, they had a 5-year overall survival that was low. And as you can see here, just around 20 to 30% after 7+3, whereas in patients with CPX pretreatment, the 5-year overall survival was around 52%, which is a remarkable number. Toxicity analyses showed no relevant differences between the two treatment options, CPX and chemotherapy. You can see here that whereas rash, headache, epistaxis, insomnia, and pruritus was more frequent in the CPX-351 arm, nausea, diarrhea, peripheral edema, vomiting, hypotension, and edema was more frequent in the chemotherapy arm. CPX is not given over 7 days, but only on 3 alternating days, on days 1, 3, and 5, as a short infusion. CPX is approved for patients with treatment-related and AML-MRC by WHO definition 2016, at least by the FDA and by the EMA. Now, if we look at the new classification of AML, MRC, myelodysplasia-related, both according to WHO and ICC 2022, the multilineage dysplasia as a criterion was removed. And there are more genetic changes which define now myelodysplasia-relatedness according to WHO and ICC in 2022. These new genetic changes are called secondary type mutations and are shown here in green. Based on a German retrospective analysis, 44% of patients with AML myelodysplasia related, according to WHO 2022, are only defined by the new genetic changes called secondary type mutations, whereas based on the old WHO 2016 classification, they would have not been referred to as myelodysplasia related. Now the question is, does CPX-351 also work in patients who only have those secondary type mutations? We don't have much evidence regarding this question yet. So far, there are only a couple of retrospective analyses. The first is from the NCRI AML-19 study, in which high-risk patients were randomized between CPX and FLAG-IDA. While CPX-351 was not significantly better in all patients, there was a subgroup analysis in patients with secondary type mutations showing a significant survival benefit from CPX-351. A retrospective analysis of the pivotal trial for CPX shows slightly higher CR rates in patients with secondary type mutations and CPX, and survival of these patients with CPX versus 7+3 also looked better. So CPX is a solid red line here, and 7+3 is a solid black line here in patients with secondary type mutations. Last but not least, this small retrospective analysis in CPX-treated patients from France shows that patients with secondary type mutations have a better overall survival than all the other patients. There is quite a high number of real-world retrospective case series now on CPX-351. However, they contain mixed patients populations, younger and older patients with and without secondary type mutations. So it is difficult to make a general statement based on these real-world data. But what we can say is that CPX is also working in younger AML patients. However, we still don't know if it works better than intensive chemo in these younger patients. And we also cannot say for sure whether it works better or as well in secondary type mutations as it does in other myelodysplasia-related changes categories. Okay, now let's move on from the induction treatment to post-remission treatment once a patient is in CR after intensive induction. How will we go on here? We have two main choices for post-remission treatment with different characteristics regarding relapse risk and treatment-related mortality, allogeneic stem cell transplantation with a lower relapse risk and a higher treatment-related mortality, and chemotherapy with relapse risk and treatment-related mortality, vice versa. The main criterion for post-remission treatment modality is genetic risk, with the majority of intermediate and adverse risk patients going to allotransplant if they are eligible and have a matching donor. Apart from these two post-remission options, there is no one more option, maintenance treatment with tablets. And there are different maintenance options, and I will quickly go through them with you. In patients without allogeneic transplantation, oral azacitidine prolongs overall survival based on the results of this QUASAR trial in elderly fit patients who achieved a CR after intensive chemotherapy. You can see that maintenance here, the yellow line with oral azacitidine, prolongs overall survival by around 10 months as opposed to placebo. In FLT3 mutated patients who do not go to allogeneic stem cell transplantation, oral azacitidine is also working. It prolongs both relapse-free survival and overall survival based on the subgroup analysis of the QUASAR study. Or midostaurin maintenance is another option for FLT3 mutated patients. However, the evidence for the efficacy of midostaurin in maintenance is quite low based on the design of the RATIFY trial that did not randomize again by the start of maintenance treatment, and also based on the results of this post-hoc landmark analysis showing no survival benefit for midostaurin from the time of maintenance start. In FLT3 mutated patients who go to allotransplant, there is a good option with sorafenib as maintenance post-allo in FLT3 ITD mutated patients based on this German study showing a significant prolongation of relapse-free survival and also a significant prolongation of overall survival. And not only this German study has demonstrated this benefit, but also this Chinese study. It also showed a significant benefit in leukemia-free survival and overall survival. But since sorafenib only inhibits FLT3 ITD and tolerability can be difficult, we were all waiting impatiently for the readout of the so-called MORPHO trial using gilteritinib versus placebo post-transplant in FLT3 mutated patients. This trial is was not only looking at the efficacy of gilteritinib, but also on the clinical relevance of FLT3 MRD. Now, unfortunately, you can see here the results of the MORPHO study. The trial did not meet its primary endpoint, relapse-free survival prolongation. Although relapse-free survival was longer in the gilteritinib versus placebo arm, the difference did not reach statistical significance, and overall survival was almost identical in the two treatment arms with gilteritinib versus placebo. One main reason for that phenomenon was that only patients with FLT3 MRD by the time of transplant or by the time around transplant actually benefited from gilteritinib treatment, whereas gilteritinib maintenance made no difference in patients who were MRD negative by the time of transplant. Now, with this slide, I sum up. In AML, we observe a paradigm change in treatment compared to just a couple of years ago when we treated every AML patient with just 7+3. We now have specific treatment concepts for genetic subgroups. We have CPX351 for treatment-related and myelodysplasia-related AML, with slight differences in definitions between the classifications from 2016 and 2022. And we have real-world data suggesting efficacy also in younger AML and secondary type mutations. We have gemtuzumab ozogamicin for CBF and NPM1 mutated, and midostaurin for FLT3 mutated AML. Post-remission treatment should be based on the relapse risk and eligibility for allogeneic stem cell transplantation, and maintenance with oral azacitidine for intermediate or adverse risk patients without the option for allotransplant is also a valid option, the same as midostaurin maintenance potentially in FLT3 mutated patients without allotransplant. And with that, I'd like to thank you very much for your attention, and I'm looking forward to potential discussion and questions.